Sorry about that.
No, that's okay.
So it's a pleasure having you here. I hope you can hear us loud and clear.
I can, yes.
I'm Dr. Yasser. I'll be the moderator for today's session, and it's a pleasure having you here.
Perfect.
An honor, complete honor.
Great. Thank you. Thank you. Glad to join you.
Assalamu alaikum, Yasser.
Assalamu alaikum, Dr. Saleh. Great seeing you.
Dr. Nora,
Okay,
hello.
no, I cannot see you.
Good morning.
Morning.
Saleh, Assalamu alaikum. This is Dr. Zishan here. And Dr. Nora, thank you for joining us.
Assalamu alaikum, Zishan.
Pleasure. Hi.
Dr. Saleh, आप finally नजर आ रहे हैं. तो assalamu alaikum once again.
Hi everyone.
I hope you can hear me loud and clear.
Loud and clear and
Yes.
cute.
I do welcome the chairs as well. I can see Dr. Rustam there. I can, Dr. Hasid
Thank
Zia
you.
as well.
Good morning, Dr. Rustam.
Well,
Thank
Dr.
you,
Rustam is good evening. He is not.
I thought he was in America.
Assalamu alaikum, Dr. Haseeb and Dr. Rustam. Sir, how are you?
How is everyone?
Thank you.
Assalamu alaikum, Dr. Haseeb. Assalamu alaikum. Good to see you after 2014, I believe.
ऐसे ही
Yeah.
we've met couple of other gentlemen and ladies from other places. आपसे शायद मुलाकात नहीं हुई.
So
Nice to
Turkey
see you.
2014,
Nice to see you.
Professor Kashif Malik, me, you.
Yes.
And I
yes,
still remember your Turkish skills, language skills.
Yes. Thank you.
So we have got still 3 minutes to start. Hopefully we'll start in time and keep the time well.
So are you going to give us a warning couple of minutes before 20 minutes?
Yes, Nadeem, but I just missed what you're talking about.
I said, could you maybe just give us a warning at minute 18?
Yes, inshallah.
Please.
Yasser, hopefully we'll keep the time well. And Yasser,
Assalamu alaikum. Good evening, Islam.
Dr. Nadeem, what do you want me to do? When
Enjoying
16
it
minutes are
to the
left,
seaside.
I'll start coughing.
Thank you very much.
And I guess the time starts when the speakers start speaking.
hopefully.
That's
Nadeem,
fine.
hello. Assalamu alaikum. You are very particular about the timing. I know that.
No,
Assalamu
I'm
alaikum,
not
Dr.
good at timekeeping. And I think what happens is I get a surge of adrenaline, and then what tends to
Okay.
happen is
Dr. Yasser, can you hear me?
Ji, Assalamu alaikum, Dr. Amjad Salamat. It's a pleasure having you with us.
Thank you very much. Can you hear me?
Loud
Yes,
and
we
clear.
can hear you loud and clear.
No, okay.
you're the lucky one on holidays.
Yeah, okay.
That's a virtual holiday. That's a
Yeah.
virtual holiday.
That's brilliant. I wish I was. Well, it's sunny out here, but
Yeah.
I guess it's not as good as out there.
So, welcome to everybody, and I think it's a pleasure seeing you, and pleasure talking to you, Dr. Hamid, after a long time.
Jesus, Assalamu alaikum.
And I think yeah, I think it's about time.
1 minute.
Yeah.
Slides are ready. So, are all the chairpersons ready so we can begin then? Dr. Shahzad Riaz is missing.
Is he in this panel? I didn't see his name.
He will be the facilitator.
Oh, okay.
Hello everyone.
Yes. Assalamualaikum, Dr. Faisal sir. Welcome.
Walaikum salam. Sir,
I
where
can
are
manage
you?
it, but if you can do that, so that would be good. Abhi, aap log, you keep trying. I'm coming back in after the introduction. So you give me the cue. I'm starting. Bismillahir Rahmanir Rahim. Good afternoon, everyone from Karachi, Pakistan. On behalf of Pakistan Society of Hepatology, I once again welcome you all on the plenary session 5 of the final day of PSH 2020. I would like to extend my deepest appreciation to our listeners and viewers who have been with us on this marathon of a scientific session. And I would like to appreciate their quest for knowledge for betterment of patient care. Today, our plenary session will highlight the curative aspect of cirrhosis, that is liver transplantation. It is going to be a 2-hour session focusing at postgraduate students, physicians, and aspiring GI fellows. Today, the facilitator for the session will be Dr. Shahzad Riaz from Islamabad. Dr. Shahzad Riaz has over 15 years of experience of working in the United Kingdom. He has worked as a consultant gastroenterologist, hepatologist in various UK-based hospitals and is currently working as a consultant gastroenterologist, hepatologist at Shifa International Hospitals, Islamabad. Our expert panel today boasts of these gems of gastroenterology, topped by Professor Sher Rahman from Peshawar, Brigadier Amjad Salamat from Rawalpindi, Dr. Rustam Khan from Karachi, Dr. Hasib Haider Zia from Islamabad. So as before, I would like to highlight a few house rules for the speakers. I would humbly request them to please follow the timeline. I understand the topics are big, but our time is our only constraint. For our viewers, our chat lines are open to address your queries. You can post your questions, and our expert panels will be happy to answer them all. And at the end of the session, we will discuss all the questions which will be requiring a direct discussion. And I hope our panelists will take part and reply to your questions in a beautiful manner. So we begin our session with the first talk from Dr. Nadeem Tehami. His topic is management of patients while waiting for liver transplantation. For those who don't know him, I would like to tell them that Dr. Nadeem Tehami is a consultant hepatologist and HPB physician with special interests in ERCP and EUS based at University Hospital, Southampton, UK. He completed his 5-year gastroenterology and hepatology training from London, Glasgow, and West Midlands. He also completed his transplant hepatology fellowship from University Hospital, Birmingham, the second largest transplant center in Europe after Barcelona. He also successfully completed HPB endoscopy fellowship from Birmingham. He is a clinical lead for autoimmune liver disease, accredited advanced endoscopy trainer, ALS certified instructor, and MRCP PACES examiner. So without further ado, Dr. Nadeem Tehami, please take the screen.
Thank you, Yasser, for the kind introduction. Hello, everyone. Thank you, organizers, for the kind invitation. Topic of my talk is the management of patients while waiting for the liver transplantation. Before I begin my talk, I would like to pay a tribute to all those who are doing a commendable service in Pakistan. And I would like to introduce this concept of a Japanese concept of reason for being. And it's important because in a country like Pakistan with limited resources, transplant hepatology requires a lot of passion, commitment, and dedication. So therefore, my salute to all those who are doing a wonderful job. Now, remit of talk is to talk about how to best optimize the patients while waiting for the transplantation. We will try to look at some of the unmet need of our patients and discuss some of the common etiologies based on EASL guidelines. Now, it's very easy to preach to those who are already converted. Liver transplantation is a gold standard treatment for many patients with acute chronic liver failure and liver cancer. And we know it makes a huge difference to the outcome of these patients. So this flow diagram displays the process from the time a patient is referred. They're discussed in the MDT. A decision is made to either list them or decline the referral. But the key thing is once a patient is listed, they must be monitored closely for changes in their clinical circumstances. Now, the local team is usually responsible for the patient's routine care, but a regular and careful communication with the liver transplant unit is essential. And the key person for this role is a transplant coordinator. Now, it's really important from transplant unit that we ensure that our patients are in best possible physical and mental health when we refer them. Now, it's not always possible. And once they are listed, it's important to ensure that these patients do not die or drop out due to the deterioration. We want to ensure that patients are in the best physical condition prior to the procedure, because we all appreciate that it is linked with the success of the post-op course and improvement in the and improve the post-transplant survival. It is also important to identify the ideal timing for the transplantation in order to minimize the mortality rates. Now, let me share some data from UK waiting list in 2016, when we had over 1,000 patients on a transplant list. We managed to transplant up to 73% of these patients. Unfortunately, 9% patient died. 4% patients were removed from the list for various reasons. And it also included a group who recompensated following treatment. And at the time of publication, 14% patients were still waiting. And who are these patients on these waiting lists? So from our perspective, we have patients who are super emergency with acute liver failure, and they are the absolute priority over all other recipients. And they usually receive a transplant within hours or days. Then comes the next group of decompensated liver disease, who are included in the waiting list on the principle of the sickest first. Now, this is mainly based on MELD or in UK with a UCALD score. And then we have patients with hepatomas with compensated liver disease. Now, let me briefly mention MELD and Child-Pugh. We still use Child-Pugh, and I include that as part of my documentation. MELD has stood the test of the time, and it nicely stratified the survival. Especially if you look at the tipping points, which is MELD is around sort of 15, and Child-Pugh BOC borderline. So this is the time when majority of patients are referred for the transplantation. But we know from our point of view, it takes weeks and sometimes months to list these patients. And therefore, from our perspective, we recommend that these patients are referred early, even when they have a MELD of around 11 or 12. It's not only MELD, we talk about MELD sodium as well. And there are many studies which show that the hyponatremia is independently associated with the survival. We know how our patient gets hyponatremia. And in fact, it was actually known way back in 1956, when Sheila Sherlock observed that patients with a liver disease who had a serum sodium level of below 130, she recommended must be regarded as serious, and if it was below 125, it was ominous. Now, it took us a long time to catch up with all our computers and modeling. So when we look at the MELD sodium, which we can calculate using one of the online calculators. Now, let me share this heat map with you. So this is a heat map, and every color line will tell you how much point we need to add to the MELD score. So on the x-axis, we have MELD score, and on the y-axis, we have MELD serum sodium. So if a patient has a MELD of 9, but if they may have a sodium of 128, we have to then add 9 to their MELD score, and MELD is actually 18. So this is a group of patients where we really want to keep an eye. And this is a group, so this group of the patients are the one who gets the most benefit out of it. And there may not be a lot of patient in this blue zone, and this is why some critics may regard that MELD sodium, although outperform MELD, but incremental benefit isn't that great because there are many patients who are out of this blue zone. So, but if a patient does fall in this blue group, this would mean world to them. So why do I still use Child-Pugh? Because there are certain things which are not included in MELD. For example, hepatic encephalopathy, which is associated, especially grade 3 or 4, with a poor outcome. And it is very hard to quantify and put it into any equation. If you talk about albumin ascites and malnutrition issues, so you may occasionally see a patient who may have a MELD of about 9 and 10, but they may have a child C. So if we just go by MELD, then we will miss a patient like this. So what we conclude that MELD is not a holy grail. There are patients who might be disserviced by using, for example, cholestatic liver disease, who patient may have a very low MELD until very late stage of the disease. Patient with refractory ascites, chronic hepatic encephalopathy due to portal cavern shunts, as we've talked about, and some patients with the hepatopulmonary syndrome. So once a patient is listed, how do we best optimize their care? I'm going to spend a few seconds on this slide, and if there is a slide that I would like you to take away from this, is this, because patients on the transplant waiting list frequently present with decompensation from their referring hospitals. And the decompensation carries a significantly high mortality risk. So this care bundle, which BSG in Basel came up with, it is so patients admitted with decompensated cirrhosis of any etiology, if it is used, then it ensures that the effective evidence-based treatments are delivered within the first 24 hours. And it is actually the first 24 hours which are particularly important, as early intervention for presentations such as sepsis, bleeding, renal dysfunction in patients with cirrhosis can reduce the mortality and shorten the hospital stay. So if you could encourage your colleagues, and especially colleagues in ER, to use this, it should transform the care of your patients presenting with decompensation and further issues. Now, do we have a magic? We don't have a magic cure for our patient with the cirrhosis. Now, albumin has been of a lot of interest to a lot of research around the globe. We know it has numerous roles. It binds the prostaglandin E2 and restores the appropriate macrophage TNF-alpha production. It binds the vasodilators, nitric oxide, carbon monoxide, endocannabinoids, and sort of helps in the management of the effective arterial hypovolemia, and is other roles of endothelial stabilization, antioxidant probabilities really help in the management of these patients. There are some established indications which you all know for hepatorenal syndrome, SVP, and for the post-paracentesis circulatory dysfunction. There was a recent trial discussing the EASL attire. Unfortunately, it was concluded that there was no difference in the primary outcome of patients. The primary outcomes were infection, renal dysfunction, and mortality. But it was done on quite sick patients. And if you compare it with the previous trial, answer, which showed a positive which was a positive trial, it was done mostly on the patient who were a bit more stable. So patients who are stable, and from their referring hospitals, they should ensure that they get a regular review, especially looking at their nutritional needs. They get their usual blood test to make sure they remain otherwise stable. And we also encourage them to have their risks stratified using different calculators, because sometimes the transfer to the liver transplant unit for acute deterioration is necessary. Now, once we maintain that, what tends to happen is that this encourages, so if there's an open dialogue between the local hospital and the transplant unit, it enhances the confidence of patient and their families as well. We also want to ensure that we manage their other complications actively. So in my practice, I tend to use a combination of diuretics, and that is because the largest randomized controlled trial, which had nearly 4,000 patients, used a combination therapy from the start. We want to avoid drugs such as ACE inhibitors and angiotensin receptor blockers, because they can lower the mean arterial pressure, which is linked with the increased mortality. I don't want to go in the debate of beta blockers, but in summary, it shortens the survival. And therefore, you need to sort of weigh the risk versus benefit in patients if you deem they have a high risk of presenting with bleeds, and manage their refractory ascites with either regular paracentesis, or sometimes we have to bridge them with TIPS. The same goes for patients with hepatorenal syndrome. We really want to avoid patient developing multi-organ damage, which could begin following an acute kidney injury or hepatorenal syndrome. This is another topic of high interest to all hepatologists all around the world, because most patients with end-stage cirrhosis are malnourished, and malnutrition in the recipient predicts poor outcome after transplant. And if we can quantify, it helps us tremendously in managing our patients. So most transplant unit recommends nutrition supplements for patients on waiting list for the beneficial effects on the anthropomorphic indices. And we also see a lot of patients with obesity, which is increasingly common in patients on the waiting list for the transplants. And sarcopenic obesity, or severe muscle depletion in setting of obesity, is reported in almost half of the obese patients with cirrhosis. And it is associated with increased risk of pre-liver transplant morbidity. Now, this diagram that you see here is of not cirrhotic patients, but when we see that there's a general sarcopenia with the passage of the age, but we know that even up to a 35-year-old young patients, physiologically, they may be as old as otherwise 85-year-old. In the BC era, we used to regard handshake as one of the fifth vital sign, and it really helps us in determining it. We've got these liver frailty index, which incorporates assessing grip, simple standing from chairs and balance. And if we are able to determine their virility, it predicts the outcome post-transplant. So what should our patients have? So with the compensated cirrhosis, the traditional lifestyle modifications are safe, but very low calorie diets, less than 1,000 calories per day, are not safe. And for the decompensated cirrhosis, low calorie diets may exacerbate the sarcopenia and malnutrition. So patients should maintain calorie intake and higher protein and nutrition-rich food. So therefore, they should have a nutrition action plan, avoiding fluid restriction and ensuring they've got a high protein in their diet. Now, patients with cirrhosis have an altered liver metabolism, which leads to the accumulation of the drugs, toxic metabolites, and higher bioavailability, and they have an altered volume of distribution. So if we take an example of the opioids, there may be some such as phenytoin, which may have unaltered pharmacokinetics, but otherwise generally we recommend using at a 50% dose of the otherwise dose and prolong the dosing intervals. Mentioned about diuretics early, that we tend to prefer combination, and it's the spironolactone and furosemide that we tend to use, and both have no major changes in the pharmacokinetics. We tend to avoid nephrotoxics, non-opioid analgesics. Paracetamol in a reduced dose can be used. Antiemetics generally have a limited or no data on the half-life of many commonly used antiemetics. And sedatives, we tend to recommend using short-acting sedatives such as oxazepam. There are other lifestyle factors which are quite central to the survival of both patients on waiting list and beyond, and patients should therefore be supported to make positive and sustainable lifestyle behavioral changes. There is a little data on the exercise in patients waiting for the liver transplant. However, exercise programs are known as pre-rehabilitation, which can improve the functional capacity and also the post-operative outcome in patients with the liver disease who are awaiting a major surgery. Active smoking can increase all-cause mortalities at 5 and 10 years after transplantation. Likewise, active engagement with the alcohol services is key for any patients with alcoholic liver disease, and in some cases, at least in our practice, it is a condition for listing as well. All patients require depression, management of depression, because we know that patients who are listed for transplant have a higher rates of psychological distress and depression, which reduces the quality of life, and it makes it very hard for them to cope with the stress that they're under. So it's both mental and physical, aggravates the both mental and physical pressure that they're under. So this is again important. Again, we have a very limited time left here, but what our patient goes through, they are in this constant trauma, physically and mental trauma. And therefore, it's another important part that needs to be paid attention now. That physicians and surgeons might not have time for this, but this is where the multidisciplinary team role becomes very apparent. And what patient perceives a high quality care, this was assessed in this qualitative study. And they interviewed the patient on waiting transplant list, and 5 themes emerged from the interviews, which could be important for the transplant centers to focus on. And these themes were, so managing the expectation, providing education, responding to the patient's need, executing the care plan efficiently, and utilizing the interdisciplinary communication and coordination of care. And we don't believe the existing quality of care measures really address that. Now, the last part of the talk, I'm just going to focus on patients who have an intermediate MELD score, and they may be waiting for a long period of transplant, especially in our setting. So the recommendation is that for hepatitis B patient, that we start entecavir and tenofovir as soon as possible if the HBV DNA is detectable. This is to improve their liver function and also to decrease the risk of hepatitis B recurrence after transplantation. For hepatitis C, the goals of treatment are, prior to the liver transplantation, is to prevent hepatitis C infection of the new liver. Also to improve the liver function to avoid the need of liver transplantation in such cases. As I showed you the data earlier, that 4% patient managed to come off the list. So if they recompensate after the treatment, they might not need it. This does not apply to every patient with hepatitis C decompensated liver disease. But hepatitis C replication at the time of transplant is not a contraindication, and antiviral treatment in some cases may be necessary post-transplantation. For alcohol, we have a favorable outcome similar to the other etiologies of the end-stage liver disease, but evaluation based on the medical and psychiatric criteria are better determine the patients who will most likely benefit from the liver transplant. For metabolically associated fatty liver disease, we talk about manipulating the risk factor for the metabolic for the metabolic syndrome, because this again determines their intraoperative and postoperative survival. If you look at the transplant outcome, the dropout rate from the transplant waiting list is about 15 to 30% due to the progression of hepatoma. And therefore, in the high-risk group, patient with a high AFP or portal vein invasion, sometimes the downstaging and bridging treatment is necessary, especially in our setting where patient might be waiting for over 6 months for the transplant. Now I'll skip the cholangiocarcinoma because it's mostly used for the patient where we are conducting studies or research, and especially if there are adjuvant or neoadjuvant therapy available. So lastly, I'm just going to mention about the palliative care, because almost half of those who are assessed in our practice are declined, and about 20% of the patient unfortunately die while waiting for the transplant. And patients suffer a high physical symptom burdens, and they've got this, especially in Pakistan, complex psychosocial issues, which obviously includes the stigma of the liver disease, complex socioeconomic background circumstances, and it is very hard to maintain the hope while ensuring that we've got an appropriate holistic assessment of patient needs. And it is a huge challenge for everybody involved. So in summary for this, an assessment for the palliative care needs should form an integral part of any transplant assessment process. So in conclusion, Mr. Chairman, ladies and gentlemen, the existing quality of care measures are stable, but they are variable throughout the world. It's important that we maintain an interdisciplinary coordination and communication with transplant units and consider treating the underlying etiology and not to forget the palliative care. So thank you very much for listening.
Thank you very much, Dr. Nadeem. Spot on talk as always, and amazingly executed, especially the part on nutrition, which our patients usually overlook because of local myths and their own beliefs, which are usually false. So coming back to our session, we have another great speaker with us today. She's Professor Nora Terror. She will talk on early versus delayed transplantation in patients with alcohol-associated hepatitis. Professor Nora is a professor of clinical medicine and surgery, Department of Medicine and Surgery, Director of Viral Hepatitis Research in Liver Transplantation. She has done her MD in 1987 from University of Alberta, and MPH in 1997 from University of California, Berkeley. She is a consultant hepatologist who is recognized internationally for a treatment of viral hepatitis and liver transplantation. Her research includes the study of viral hepatitis and its progression and treatment, especially in liver transplant patients. Another feather in her hat include research with several clinical trials related to preventing and treating chronic hepatitis C and B. Her studies in this area have been presented to the American Association for the Study of Liver Diseases. Dr. Nora, you are welcome on screen.
Very good. Thank you. I want to thank the organizers for inviting me. It's really a pleasure to participate in the meeting. It's remarkable, really, to be able to see you all sort of virtually. So thank you very much for the invitation. And while much of my career has been focused on viral hepatitis, in the more recent years, I've become very interested in the area of alcohol-associated hepatitis. And today I'm going to be speaking with you on the somewhat controversial topic of early versus delayed transplantation. So alcohol-associated hepatitis, as you know, is quite a unique syndrome, requires, by definition, chronic and active heavy alcohol use. It presents as acute on chronic liver failure. Individuals may or may not have underlying cirrhosis. the jaundice is accompanied by this systemic inflammatory response, or SIRS, and it's this SIRS that's largely linked with a very high mortality. Individuals have a 90-day mortality that can range from 30 to 60%, depending on severity. And as you know, the therapies for severe alcohol-associated hepatitis are very limited, with corticosteroids being really the only one available. As a consequence, liver transplantation in recent years has come under consideration for select individuals with severe alcohol-associated hepatitis. And shown here is an algorithm from a recent review, which captures the guidance on this in several of the, at least US guidance, which has now incorporated liver transplantation into algorithms for management. So for an individual who has probable or definite alcohol-associated hepatitis, if they have a contraindication to corticosteroids, as is shown here, that cannot be reversed, then that individual should then be considered for liver transplantation as a rescue therapy. For those that are candidates for steroids, of course, steroids should be considered first. We would evaluate their response to steroids at 1 week using the Lille score, and non-responders at 1 week, again, should be referred or considered for liver transplantation. As we'll talk about, being referred or being considered for liver transplantation is quite different than actually being listed for liver transplantation. There's a lot that goes into the selection of these candidates. But what's new is the idea that we would consider transplanting these individuals, recognizing that they often have heavy and recent alcohol use when they present with this condition. And the landmark study that led to us considering liver transplantation for this indication came from Philippe Maturin and the group, a Belgian-French group. This was published now back almost 10 years ago. And what they did in this study is it's a relatively modest number of patients. You can see 26 patients here compared to 26 matched controls. So they offered liver transplantation to a select number of individuals with severe alcohol-associated hepatitis, defined by a discriminant function greater than 32, non-response to steroids, and a Lille score after 1 week of 0.45, so non-response to steroids. You can see that the individuals who are offered transplantation, when you look at 2-year survival, is dramatically improved compared to matched controls who are not offered transplantation. And again, this outcome was achieved with no mandated period of sobriety before liver transplantation. I mentioned several times already that it's a select number of individuals who move forward to transplantation. And in this original French study, the main criteria that they used are shown on the left. So as I mentioned, they were unresponsive to medical therapy. Importantly, this had to be their first decompensating event, meaning that they weren't previously hospitalized with alcohol-associated complications, no history of severe psychiatric or diseases or drug dependence, presence of close supportive family members, and agreement by patients with support from family members to adhere to lifelong alcohol abstinence. And importantly, they had a review of all members of the team. So starting with the nurse, the resident, and the fellow, they first evaluated the patient and had to agree that the patient was a suitable candidate for liver transplantation. And then you can see these concentric circles of evaluation, including the addiction specialist, the senior hepatologist, and ultimately the surgeon and anesthesiologist. And in all cases, the entire group had to agree that this patient was an excellent candidate for transplantation in order for them to be actually listed. And what you can see is that very few of the patients met those criteria. So this is just a cartoon, but highlighting the data we have on how many patients with severe alcohol-associated hepatitis actually would be transplant candidates. And as you can see here, if you start with 100, of course, there'll be a significant proportion that will be responders to corticosteroids and therefore not require transplantation. But of those that are non-responders, only 10% of those are eligible for transplantation. Only 3% of the total that present with severe alcohol-associated hepatitis. And you can see that the most common reason why individuals are excluded from consideration of liver transplantation is a poor psychosocial profile. So what this tells you is that while I'm going to talk to you about liver transplantation as being a therapy for severe alcohol-associated hepatitis, many will not be candidates, and this highlights the high unmet need for therapies to treat moderate to severe AH. Now, very recently at the EASL meeting this year, the Franco-Belgian group provided a follow-up study. It's a much larger study. This time 155 patients were transplanted for severe alcohol-associated hepatitis. And I'm going to show you, first of all, the survival data. And here what they did was compare those that were candidates for early transplantation compared to those that had severe alcohol-associated hepatitis but didn't qualify for early transplant. Again, we have a 2-year follow-up, and it's very, very similar results to their early study, which had only 26 patients. This was much larger, but reaffirms the benefit of early transplantation for patients with severe alcohol-associated hepatitis. But this study also, because it was a prospective study, captures the main risk. So I think the concern with transplanting patients who've not had a mandated period of alcohol sobriety before transplantation is what is their risk for relapse of alcohol use after transplantation. And they did a very careful look at this in this study. And shown on this graphic is the cumulative incidence of first alcohol relapse after transplant. So again, the 155 patients that were unresponsive to medical therapy are compared to those, in this case, that underwent transplantation, were compared to, in this case, patients who were transplanted at the same institutions for alcohol-related liver disease, but who had 6 months of abstinence. So really comparing it to what most of us would consider the gold standard currently for consideration of transplant. And what you can see here is that the rate of alcohol relapse was not significantly different between the groups. It was 33.8% for those that were transplanted for severe alcohol-associated hepatitis versus 24.7% in those with cirrhosis. The absolute difference was 9.1%, which was less than the criteria they set as a non-inferior, which was 10%. So they concluded that they were not statistically different. They looked at the profiles of alcohol use after transplant as well, and showed that there were some differences, and the primary one was the rate of heavy alcohol use. So here we have time spent with alcohol use, rate of heavy use, and time spent in heavy alcohol use. And you can see the one area in which we see the difference between those who were transplanted for severe alcohol-associated hepatitis versus alcohol-associated cirrhosis is a much higher likelihood of heavy alcohol use. But keep in mind that despite this use of alcohol use, that the survival at 2 years was still excellent at over 80%. So now I'm going to shift to the US and to the study that I've been involved with called Accelerate AH. This is an observational cohort. In contrast to the Franco-Belgium study, it's a retrospective cohort. It involves 12 centers that represent 8 UNOS regions in the United States. I'm at Keck Medicine of USC, which is one of the sites. We've published data. The first was a cohort of 147 consecutive patients who were transplanted at each center with severe alcohol-associated hepatitis between 2006 and 2018, with most of them having been transplanted between 2016 and 2018. The key inclusion criteria for this cohort are very similar to the Franco-Belgium cohort. You can see they use a MADRI score greater than or equal to 32. No prior episodes of alcohol-associated hepatitis, and no prior diagnosis of chronic liver disease or prior presentation. Again, no minimum period of abstinence was required. The exclusion criteria, we'll talk about the psychosocial profile shortly, but the other usual criteria for liver transplantation were also used. The patients, just to give you a flavor for what they look like, the median age was 42 years. They were predominantly male. About a half were employed. 1/3 had a history of psychiatric disease, but it was treated. 1/3 had had a history of failed rehab attempts. 29% had alcohol-related legal issues. The median pre-abstinence alcohol use was 10 units per day and 15 years of heavy drinking. And the days from last drink to transplantation were on average 55 days, but ranged from 36 to 91. You can see they're very sick patients with a median MELD score NA of 38, and the median time from being listed to transplanted was 7 days, reflecting their high MEL scores. So similar to the Franco-Belgium experience, here we have results out to 3 years, but the median follow-up here at that time was 1.6 years and our survival was 84%, so quite comparable. And we too evaluated and compared transplantation for alcohol-associated hepatitis to alcohol-related cirrhosis, where a mandated sobriety period was used. And again, we found no difference in survival between those two groups, highlighting that the requirement, the fact that the alcohol-associated hepatitis patients don't have mandated sobriety periods didn't influence survival. We too have looked at alcohol use post-transplant. This is based on clinical interviews of the patients and families, occasionally based on evaluation of liver biopsy for abnormal liver tests, but very frequently we use biomarkers to evaluate for the presence of alcohol use. And you can see here that with follow-ups out to about 3 years, that 34% have some alcohol use, and the median time to first alcohol use in our cohort was 160 days. And we've looked at not only do they relapse or do they use alcohol after transplant, because we know that alcohol use disorder is a chronic disease, and so patients may slip, but then regain sobriety. And so we looked at patterns as well. And we show on the y-axis here patterns at the bottom are individuals who are abstinent, and we had 70% of the patients were abstinent with this is data out to 60 months post-transplant. So overall, the majority of the patients were actually abstinent. And then we had 3 patterns. We had a pattern of late non-heavy use, where they were either non-frequent or non-binge drinking. And we had 2 patterns of early use, with the most, with the pattern of early heavy representing patients who started drinking early after transplant and either had frequent or binge use. And what we found in our analysis was those that had this early use of alcohol was really the highest risk group. That's shown here, where their survival at up to 5 years now is 75%, compared to our abstinent group, in which our survival was 92%. So indeed, relapse of alcohol use, particularly when it is early, and heavy, is particularly a negative for patient outcomes. So clearly, offering this life-saving therapy in order to achieve these outcomes, patient selection is very, very important. And I highlighted the French Franco-Belgium approach and main criteria. There was recently a consensus conference held in Dallas among the US community looking at this indication for transplantation. And they came up with a list of what they view as a favorable psychosocial profile. Importantly, it should be the first presentation with decompensation. So individuals who had a long history of repeated hospitalizations, for example, would be excluded. Absence of severe uncontrolled medical or psychiatric comorbidities, not being intubated, because it's felt that it's important to be able to assess the patient directly regarding their commitment to sobriety. And so an inability to do that is viewed as a negative factor in terms of the psychosocial profile. Lack of repeated unsuccessful attempts of rehabilitation, lack of other current substance abuse, dependency, an acceptance of their ALD diagnosis with insight, commitment to lifelong sobriety, and the presence of close supportive family members and caregivers. Within the Accelerate AH, we have looked at the factors that are associated with sustained alcohol use after transplantation and came up with a predictive score we call SALT. SALT is made up of 4 factors that we found were the most important in terms of predicting a person's likelihood of not drinking after transplant. And those factors include multiple failed rehab attempts, more than 10 drinks per day at presentation, a history of alcohol-related legal issues, and a history of non-marijuana illicit drug use. And what the SALT score does is identify individuals at low risk. So it has a high negative predictive value. So if you have someone who has a very low SALT score, so very few of these elements, then you can be confident that this individual is going to be without alcohol use after transplant. Unfortunately, the SALT score is not very good in terms of positive predictive value. So its PPV is only 25%. So the use of the SALT score is really just as a guide to give you a sense of whether you have a candidate who's unlikely to drink post-transplant or have sustained use, but it shouldn't be used solely to exclude patients from consideration of transplant. And then I'm going to close with a recognition that alcohol-related liver diseases are related to a chronic disease, alcohol use disorder. And so if we're going to take on the transplantation of these patients, we have to also take on the management of alcohol use disorder. And the strategies can occur both pre and post-transplant. Often the time we have with patients with severe alcohol-associated hepatitis is very short before transplant, so we don't have a lot of time to engage them. But we should make efforts, even during the hospitalizations, to engage them in addiction to be evaluated by and build a relationship with the addiction medicine team or the psychiatric team to think about how we might use medications to reduce craving and to establish a program for monitoring of alcohol use after transplant. And of course, because anxiety and depression can often be linked with alcohol use and exacerbate it, treatment of those conditions is important. But really, for transplant hepatologists, our real focus is post-transplant. And what can we do there? I'm going to show you data that highlights the importance of integrating support for abstinence into post-transplant care. We should use medications that support abstinence through decreased craving, monitor for alcohol use, including use of biomarkers, and be prepared that if the patient slips, that we're there to support them to regain sobriety. And here's, I think, an important study that looked at the benefits of having an embedded alcohol addiction unit in the post-transplant unit. This is for patients that have alcohol-associated liver disease, cirrhosis. But what they showed in this study was that having a unit that was embedded in the transplant group was associated with lower likelihood of seeing any alcohol use post-transplant. And so that was viewed as an important mechanism for supporting patients for sobriety. Indeed, I told you about the Dallas Consensus Conference. They also had pretty strong recommendations about what they felt transplant programs should offer if they're going to undertake the transplantation of severe alcohol-associated hepatitis. And they were that the program should have documentation of an AUD, alcohol use disorder management program, pre and post-transplant, have ongoing support of abstinence with dedicated addiction medicine or psychiatric specialty, have robust monitoring for alcohol slips and relapse, including use of biomarkers. And they also felt that it should be a criteria that transplant programs provide data on their sustained rates of alcohol use post-transplant as a marker of their commitment to supporting patients towards abstinence. And it really emphasized the importance of a liver transplant center's need to have expertise in managing alcohol use disorder. So to summarize liver transplant for this very unique condition, it's viewed as acceptable and achieves excellent outcome in select patients. Remember that we're selecting those with their first decompensating event and with robust psychosocial profiles, but that this mandated sobriety period is not required. There is this need for a very careful psychosocial and addiction medicine assessment, and I've highlighted some of the factors that are viewed as being important in predicting a candidate who's going to not be using alcohol after transplant, and that liver programs must expect to manage alcohol use disorder and have the right team in place to do so, recognizing that relapses will occur. Thank you very much.
An amazing talk, and your presence is always electrifying for the audience. And I would like to encourage our participants who are watching us live that it's a great opportunity to interact with our international panel of experts. And we are very active in answering your question in the Q&A sessions, and as well as we will pick up some questions which are of a burning nature, and we will discuss with all our panel invited. So the next talk for today is going to be by another gem of a gastroenterologist, Dr. Ubaid Sheikh from USA. The topic that he will be covering will be impact of age and obesity on outcome of liver transplant. Dr. Ubaid Sheikh is an MD, FRCP consultant gastroenterologist, Director Transplantation Medicine, VA Pittsburgh Health System. Dr. Sheikh is a professor of medicine whose research efforts focus on progression of end-stage liver disease, treatment of hepatocellular carcinoma, hepatocarcinogenesis, and genomic profiling of liver tumors, and allocation of models for liver transplantation. His main focus of clinical interest is viral hepatitis and hepatocellular carcinoma. So, Dr. Ubaid Sheikh, please take the screen.
Good afternoon. First of all, I'd like to thank the organizers of this meeting and the president of the Pakistan Society of Hepatology for inviting me to give this talk. I was asked to speak about the impact of age and obesity on outcome of liver transplantation. Here are the learning objectives: to evaluate the physiologic and functional effects of aging, to assess the impact of sarcopenia and frailty on waitlist and post-transplant morbidity and mortality, to examine liver transplant candidacy among older adults, and to identify the effects of obesity on liver transplant candidacy and post-transplant outcome. Aging is a fact of life. By its very nature, it is the consequence of living itself. Aging has physiologic and functional effects on various organ systems. In liver transplantation, one has to consider the effects of aging on both the recipient and the donor organ. In this talk, I will focus on the transplant recipient. In the early days of liver transplantation, a donor age of greater than 50 was considered to be a relative contraindication. However, over the subsequent years, liver transplant in older individuals became more acceptable. Aging has multiple effects on the human body. In particular, there is a wider recognition of the effect of sarcopenia, frailty, and comorbidities on the outcome of liver transplantation in older adults. Sarcopenia is a syndrome that is characterized by progressive and generalized loss of skeletal muscle mass and strength. It increases the risk of adverse outcomes such as physical disability, poor quality of life, and death. The diagnosis of sarcopenia requires the presence of low muscle mass and either low muscle strength or low physical performance. Both elements of criteria are required because muscle strength is not entirely dependent on muscle mass, and the relationship between strength and mass is not linear. This picture provides a comparison of a young, healthy thigh muscle and a sarcopenic thigh muscle. As it is obvious, there is abundant muscle mass in the healthy thigh muscle. In comparison, in the sarcopenic thigh muscle, there is a significant loss of muscle mass. This slide depicts the mechanisms of sarcopenia. There are multiple factors that influence the development of sarcopenia. Those factors include endocrine dysfunction, neurodegenerative diseases, inadequate nutrition or malabsorption, and disuse secondary to either immobility or physical inactivity. Primary sarcopenia is age-related, and it occurs due to a deficiency in sex hormones and due to the development of apoptosis and mitochondrial dysfunction. Sarcopenia can be established by measurements of muscle mass, muscle strength, and physical performance. In clinical practice, muscle mass is usually determined by imaging, either with computed tomography or MRI. More recently, DEXA scan has been introduced to evaluate muscle mass. Bioimpedance analysis is another way of assessing muscle mass. Muscle strength can be determined by measuring hand grip strength. This is one tool that can be used to determine hand grip strength. Physical performance can be determined by the gait speed or by get up and go test. Here is a suggested algorithm for assessment of sarcopenia. First, you measure gait speed. If the gait speed is greater than 0.8 meters per second, one could measure the grip strength. If the grip strength is normal, there is no sarcopenia. On the other hand, if the gait speed is equal to or less than 0.8 meter per second, then you measure the muscle mass. In addition, if the grip strength is low, you again measure the muscle mass. If the muscle mass is low, there is sarcopenia. If the muscle mass is normal, there is no sarcopenia. So there are two routes before you measure the muscle mass and determine there is sarcopenia. One is by first determining the gait speed. If it's less than or equal to 0.8, then you can go straight to muscle mass measurement. However, if the gait speed is higher than that, one should measure the grip strength first. And if it is low, then you measure the muscle mass and determine whether there is sarcopenia. Walking speed is a good predictor of outcome. For example, if the walking speed is less than 1 meter per second, there is need for intervention to reduce falls. If it is less than 0.6 meter per second, then that is indicative of dependence in activities of daily livings and a higher likelihood to be hospitalized. A simple walk test can be developed in the clinic and an easy and convenient measure to determine functionality. The next concept is that of frailty. Frailty is a syndrome that was initially developed and described in the geriatric population. It results from age-related cumulative declines across multiple physiologic systems. It reflects impaired homeostatic reserve and reduced capacity to withstand stress that results in increased vulnerability to adverse health outcomes, including falls, hospitalization, institutionalization, and mortality. Diagnosis of frailty is supported by 3 or more of the following features: unintended weight loss, exhaustion, weakness, slow gait speed, and low physical activity. Frailty and sarcopenia overlap. Most frail older individuals exhibit sarcopenia, and some older people with sarcopenia are also frail. So how do we put this all together in the decision-making for liver transplantation and to predict the outcome after liver transplantation? In the United States and many countries, MELD is used to allocate donor organs. MELD predicts 3-month mortality among patients with cirrhosis. However, it does not capture extrahepatic complications of cirrhosis that have impact on mortality, such as sarcopenia, malnourishment, and functional decline. In view of those issues, liver frailty index was developed to capture such features and to enhance mortality prediction in patients with cirrhosis. The index includes grip strength, chair stance, and balance. In the validation study performed by the original authors, compared to MELD alone, combination of MELD and liver frailty index correctly reclassified 19% of patients. In another multi-center study, frailty was associated with the waitlist mortality independent of ascites and hepatic encephalopathy. Although older individuals are more likely to be frail, frailty is independently associated with waitlist mortality. Pre-transplant liver frailty index is a predictor of post-transplant robustness and strength. The American Society of Transplantation Working Group has therefore recommended that frailty should not be the sole criterion for delisting or non-listing a patient for liver transplantation. It should be one of the criteria when evaluating transplant candidacy and suitability. One of the issues we face as transplant physicians in the US is the increasing number of older transplant candidates. An SRTR database study of liver transplants between 2003 and 2016 showed a fourfold increase in transplantation in older adults, i.e. those equal to age 65 or older. However, on a positive note, despite this increase in number of older recipients, there was significant decline in length of stay, rates of rejection, graft loss, and mortality over time. Similar outcomes have been noted in living donor liver transplants. Patients should therefore not be excluded from liver transplant solely based on age. The severity of sarcopenia and frailty should be considered in the decision-making process. Now I will turn to obesity and liver transplantation. NASH and alcoholic liver disease are currently the leading etiologies among adults listed for liver transplant in the US. This is particularly prominent among patients without hepatocellular carcinoma. Obesity is the most common risk factor for NAFLD and features of metabolic syndrome, including diabetes, dyslipidemia, and hypertension, which are prevalent among such patients. The most common cause of death among patients with NAFLD is cardiovascular disease, followed by liver disease. Among liver transplant candidates, patients with NAFLD or NASH have the highest waitlist mortality. Additionally, during perioperative period, obese patients are more likely to develop non-operative biliary complications, wound and other infections, and they are likely to have longer lengths of stay. However, there is no difference in graft and patient survival between obese and non-obese individuals. In contrast, those with morbid obesity, i.e. with a BMI of 40 or greater, have reduced rates of survival. Among liver transplant candidates, management of obesity is challenging. Weight loss surgery is contraindicated among patients with decompensated disease and clinically significant portal hypertension. In addition, it is difficult to institute dietary measures because of the risk of worsening sarcopenia, frailty, and malnutrition. So it is important to optimize management by establishing a multidisciplinary obesity team. One possibility is that of hepatology to liaise with bariatric surgery, endocrinology, dietitian, physical therapy or fitness and sports medicine experts, nursing, psychology, and gastroenterology. So all these members of the team can work together to manage the patients, and that will likely lead to a better outcome compared to the patients being individually managed for obesity. So here are my conclusions. Aging has physiologic and functional effects. Older individuals are prone to develop sarcopenia and frailty that adversely impacts waitlist mortality and transplant outcome. Transplant candidates with NAFLD or NASH have increased waitlist mortality and higher rate of perioperative complications. Recipients with morbid obesity with a BMI of 40 or greater have higher post-transplant mortality and morbidity. One should consider such factors in the decision-making process for liver transplantation. However, patients should not be excluded solely on the basis of age. At the end, I'd like to mention Dr. Starzl, who pioneered liver transplantation and with whom I had the honor of working on research projects together. I thank you.
Trubat Sheikh. It was a wonderfully summarized presentation. So moving on, we will be moving from our international colleagues to our national gems. We have the honor of having with us Dr. Faisal Saud Dar from Rawalpindi. He's FCPS, FRCS, and holds a Sitara Imtiaz. Dr. Faisal Dar is the pioneer of liver transplantation in Pakistan. He works for New Life Health Services at Quaid-e-Azam International Hospital, Islamabad. He is the leading liver transplant surgeon in Pakistan and has successfully completed over 1,200 transplant surgeries in his care. Dr. Faisal Dar's contribution in the development of liver transplantation was recognized by the government of Pakistan, and he was awarded Sitara Imtiaz by the Honorable President of Pakistan in 2016. He was awarded the BMJ South Asia Award of 2017 as the Best Surgical Team of the Year for developing liver transplant service in Pakistan. He has been awarded the Zenith Global Healthcare International Healthcare Professional and Special Recognition Award in 2018 as well for developing liver transplant, hepatobiliary and pancreatic surgical services in Pakistan. 1,200 plus living donor transplants, Sitara Imtiaz, BMJ. There are so many awards to his name, I cannot even summarize in one sentence. So I would like to welcome Dr. Faisal Saud Dar to the screen, and he will tell us about the surgical challenges in living donor liver transplantation. Dr. Faisal, please take the screen.
Okay. First of all, I would like to thank Pakistan Society of Hepatology for their kind invitation. And thank you for sandwiching me in such a passionate hepatologist and giving me the only surgical talk of the session. So I will try to do a bit of a justice with the talk, although it is quite difficult to discuss and share all the surgical pains which we go through doing living donor liver transplantation. But the story of liver transplantation, I think, goes back to the concept of liver regeneration, which is well known at least from 3 centuries, as it was nicely depicted by Michelangelo's and Theodore Rembrandt's paintings of an eagle eating the liver of Prometheus, and only for it to regenerate back the next day. So that is the concept which has been used by the modern day liver surgeons to do major hepatectomies and do living donor liver transplantation. I think fundamental to the success of living donor liver transplantation has been the knowledge of liver anatomy. The sectoral anatomy was described by a French surgeon named Cugnot. And also fundamental to this is the physiological knowledge of liver. The basic unit of liver, which functions as a liver, need to have an arterial flow, a portal venous flow, and an outflow, and the drainage of the bile duct. So no matter whether it's an acinus of the liver, or it's a segment, it's a lobe, or a whole liver, if these 4 structures are in a natural order, only then the liver is going to function as a normal function. And that has to be considered in living donor liver transplantation, where you are bound to take only one side of the liver. And God has given us plenty of liver, and by the generous efforts of the donors, the living donor transplantation has been possible. There are different ways to calculate the amount of liver which has been gifted to us. It is slightly higher in male than females because of their body habitus. But there is a certain lower side of the limit which needs to be transplanted to meet the metabolic needs of the recipient. Otherwise, we can refer it to as a small for size. And actually, even if we look at all the patients with advanced liver diseases, actually their liver is still working, and that is why they are alive. Without a liver function, to best of my knowledge, one cannot survive more than 24 hours. And I have the experience of two patients. They were without a liver, waiting for an urgent transplant, and we could maintain them with different medical things, dialysis, ongoing sugar, and all those things. One for 2 days, another was a child for about 5 to 7 days. And eventually they died with a metabolic crisis and sepsis. So you need to have a minimal and a critical mass of the liver, which in living donor liver transplantation is defined as a graft recipient body weight ratio. And nowadays it is quite easy to calculate the volumes of the liver by CT scans, because the CT scan has become very sophisticated. And you can use three-dimensional images to map the vascular and the biliary tree. By definition, I would say living donor liver transplantation is a small for size graft, because you are not giving what we have been endowed by the nature. So if the graft recipient ratio is less than 0.8, and you have to remember that normally liver is about 2% of your body weight. And in a living donor liver transplantation, you are aiming to give at least 0.8% of your body weight. That was the definition which was there from about 15 years ago. And now the definition actually for graft recipient ratio has been further cut down to 0.7. And although in practical, we do even lower volume of livers for transplantation. This generally presents as high intraportal pressures. The anterior sector of the liver looks congested. Patient had coagulopathy, high bilirubin, high volume ascites in the post-operative period in the first week to 10 days. And generally these patients die of a small for size, and sepsis remains the final hit generally by the end of the second or by the mid of the third week. So living donor liver transplantation are small for size grafts, and that is the concept I want to build. And the hepatic venous outflow has been fundamental to the contribution of small for size syndrome. As earlier I said, the living donor grafts are small for size to start with, and then the different technical factors add further insult and leads to further volume loss by the defaulty position of hepatic veins or incorrect surgical techniques. So for a balanced liver function, as we discussed in the first few slides, you need to have an adequate portal flow distributed nicely over the liver parenchyma and then exiting out through the hepatic veins. If there is a disbalance, and in cirrhotic patient, you always have a high portal flow going through a smaller graft and coming out through the even smaller hepatic veins. And that leads to sinusoidal injury, and that further accentuates small for size syndrome. So I would like you to compare it with cadaveric liver. When you get a whole liver, and you can see you have the inferior vena cava, and that the graft, which is a whole liver, being anastomosed. The whole liver parenchyma is a bed for the whole portal flow to be distributed nicely. And then you have 3 hepatic veins, which takes the blood out of the liver. So until unless you have gone terribly wrong in anastomosing the inferior vena cava, there should not be any outflow problems. And in the whole liver setting, the problems in outflow are only 2%. And if you compare it to living donor transplantation, you have a right hepatic vein there, which is your predominant outflow vein in a right lobe graft. And you have a portal flow, which is very high in cirrhotics, going through one lobe of the liver, and this outflow has to come out through a smaller vein. And if this outflow is technically defaulted, you are going to have a liver which is congested. And as you know, the congested parenchyma does not work as a normal liver, and that will further contribute to small for size. And this is further complicated if the nature has given a difficult anatomy to the donor. So instead of having a single big right hepatic vein, you have 3 smaller hepatic veins. So that is making things a little more challenging. And you can see 3 hepatic veins on the back of the liver and a cut surface veins, which you have to reconstruct with synthetic grafts. And working in just a living donor setting where you don't have a backup support of cadaveric blood vessel, you have to use these synthetic grafts to reconstruct the segment 5 and 8 vein. So the transplant has to be perfectly technically executed if you want to get a desired outcome. And there has been different ways to reconstruct the hepatic veins, much complicated by the Koreans, by different techniques, but I think is much more simplified nowadays. And the knowledge of outflow, I think, stems back from the law of physics, which has been nicely explained by the Hagen-Poiseuille equation and the law of Laplace. So what you simply need to assume is that you have a laminar flow. The blood is a laminar flow through the hepatic veins. So I am not going to go into details of the turbulent flow. And it is dependent on the diameter of the blood vessels, viscosity of the solution, and obviously the wall tension. The only thing you can control here is the diameter. And that can be controlled in a very small fraction, because the right hepatic vein has a diameter which you actually cannot change. Although different people do clamp the inferior vena cava, make a bigger opening in the recipient's inferior vena cava, and try to make this opening even bigger. But in my view, that doesn't make any sense, because you cannot make the right hepatic vein of the graft bigger. So what you need to do is you need to execute this anastomosis technically perfect. And what actually happens is, just for an example, this is about a 1.5 centimeter right hepatic vein. And once you put this graft into the hepatic fossa of the recipient, you have a orientation of the hepatic vein, which is vertical on the inferior vena cava. So you have to stitch it up. And if your stitch is about 10 to 15 degrees right or 10 to 15 degrees left, and then you give a big portal flow, the graft is going to swell up. And then later on, the graft has to regenerate left-right. So if this anastomosis has a fault of 10 to 15 degree, by the rotation of the graft due to high portal flow and regeneration, this angle which you have created at the beginning is going to accentuate further. And if you go back to the Hagen-Poiseuille law, the diameter, 1/4 of the diameter, is proportional in the turbulent flow. And the flow actually changes by 2.5 times if you just change the diameter in 1/4 fashion. So by rotating the graft, if you are decreasing the diameter by 1/4, actually you are reducing the flow across this anastomosis. And all it's going to lead to is congestion of the interior sector of the liver. So it's a big portal flow going into this liver, and maybe half of the liver is actually already congested. So this was a small for size graft, and now with the technical error, the anterior sector is congested, and this liver is going to get hepatocellular loss in the interior sector, and that means this is going to be even smaller per size. And that leads to graft dysfunction, sepsis, and death. So you have to recognize all these factors intraoperatively. And the measure which you can do, one, to get the anastomosis perfectly right, the liver needs to look good. It has to be documented nicely with the intraoperative Doppler flows, with the flow patterns. The hepatic vein needs to have a triphasic flow. And even the pressure is still higher, you can either ligate the splenic artery, you can do a hemiportocaval shunt as depicted in this picture, or you can do even a splenectomy, or you can combine all three if the portal pressure is very high. And if it is recognized post-operatively, you can give propranolol, you can give terlipressin, you can embolize the splenic artery. But by the time actually you recognize it as a small for size syndrome, by and large, it's already too late, and there has been a lot of sinusoidal damage leading to graft dysfunction. It is very difficult to rescue this small for size graft. The other way to deal with the small for size graft is doing dual graft transplantation. So that means we are transplanting two lobes from two donors. One is obviously a right lobe. The other one can be a left lateral segment from the second donor or the left lobe from the second donor. That makes a double transplant in the recipient. You get a good volume of the graft, but obviously you have now increased your technical challenges by doubling up the size of the blood vessels, which you have to anastomose, increasing the risk of technical complications. We have done about 18 dual graft transplant in the last few years, and increasingly, and we were doing more dual graft in the early part, and later on when we learned to deal with a small for size graft, I think dual grafts are very few in the last couple of years. But we did try to analyze these, and we came up, this paper is not published yet, it's in the process. What we analyzed that actually if the graft recipient ratio is less than 0.7%, and this is a modern definition of a graft recipient ratio, this for a small for size graft, you are actually better off with the selective portal flow modulation rather than doing a dual graft transplantation. Then I would like to mention about auxiliary liver transplant, because this is also a technical challenge. It can be either done in a cadaveric setting or in living donor setting. There are basically two main indications. One is acute liver failure. When somebody is young, has sudden insult to the liver and the liver fails, and the only way to save their life is a transplantation. In the liver for their survival, so you cannot rely on the native liver for liver function of the native liver and transplant a right lobe, and later on monitor the patient for the first year or two. If the native graft regenerates, and you monitor this regeneration by liver functions, by doing serial biopsies, by doing HIDA scans and looking at the fractional functional of the native or the grafted liver. You can also do CT scans measuring the relative volumes of both the livers. And if one is satisfied that the native liver has regenerated, then obviously the patient can be gradually tapered off of the immunosuppression. That would lead to further hypertrophy of the native liver and atrophy with slow chronic rejection of the grafted liver. And these patients will have the advantage of taking off the immunosuppression completely. The second set of auxiliary transplant is done in children in metabolic liver diseases. Especially the main indication has been Crigler-Najjar syndrome over the years. And actually it started with the hope that gene therapy is soon going to come, and it's just around the corner. This matured the technique of auxiliary liver transplantation, but the gene therapy, actually, we have been in so many rounds, but we have not reached that corner yet where gene therapy is available. But the advantage of doing auxiliary liver transplant in Crigler-Najjar is that if your transplanted liver fails due to technical issues or otherwise, you still have a native liver which will perform other functions, but obviously the patient will have a Crigler-Najjar back. And since these are children, there is still a hope that maybe in 5 years, 10 years, or even 20 years, maybe the gene therapy is discovered, and even then these patients can be taken off the immunosuppression if they have their native liver. And this is a very interesting concept of a metabolic chimera, where based on the concept of auxiliary liver transplantation, where you don't need any donors. You can have two children with two metabolic diseases, like for example, one is Crigler-Najjar and the other is propionic acidemia. You can swap their livers. So one defective genotype will actually, two defective genotypes will correct each other, and you have a normal phenotype. So the liver from Crigler-Najjar is transplanted into a propionic acidemia child, and that will correct the propionic acidemia in that child. And similarly, the liver from propionic acidemia child is transplanted into Crigler-Najjar, and that will obviously correct the Crigler-Najjar syndrome. So you don't need a donor in this transplant. And in children, there is a large first size transplant as well. As we discussed the small for size, 1 year of age or at times 2 years of age for metabolic liver diseases. Their belly is not big, and the left lateral segment or a left lobe from their parents who are living donors at times can be very big for these small children. So large for size syndrome is generally defined when the graft recipient ratio is more than 4, and it is known to have actually a poor outcome. And the main reason for poor outcome actually is technical. And you can see from this picture, this was a big liver, a left lateral segment, but we have to cut it down to make it as a monosegment graft. But even then, it was big enough that we could not close the child's belly, so you have to put a silastic mesh. And as we know, liver is an amazing organ. It regenerates very aggressively when you need it. But at the same time, it atrophies as well very quickly when you don't need it. So in children, if they got such a big liver, their portal flow is not that massive. So their portal flow, the portal way is small, the volume of the blood is small, so it is not going to perfuse most of this liver. So the portal flow will actually perfuse most of the liver in the center. So the periphery of this liver will not get a portal flow. So if it's not going to get a portal flow, it is going to atrophy in the next 2 to 3 weeks. And this belly, which you cannot close at the time of transplant, you will be amazed that in 2 weeks' time, you can easily close the belly of this child. The technical challenges are more serious in terms of the vascular, like hepatic artery, portal vein, which I have not touched in this talk because of the limitation of time. But I think all the vascular issues are fairly difficult, but can be sorted out. In my personal view, bile duct remains a problem. And we don't have the liberty of having too many living donors to select the best one with a simple and a straightforward biliary anatomy. And you come across with variable type of a biliary anatomy which you have to deal. And these ducts, quite a number of times, actually are not picked up while you are evaluating these donors on an MRCP. And it is not uncommon to get surprises when you do an intraoperative cholangiogram. So now you are stuck, you have to deal it whatever the way you think. But pushing yourself and accepting donors with difficult anatomies means you are increasing the risk of biliary complications in the recipients. And finally, I would just like to touch upon the failures to rescue concept. Failures to rescue concept is very important in living donor settings. This is a quality assessment matrix where basically a high mortality in centers is not just the best surgical techniques or the best selection of patient. It is the cohesive management or a multidisciplinary management of the whole transplant team, which actually transforms the outcome of transplantation. The center who have more experience have a very low failures to rescue scoring because their systems are so strong. They are very skilled individual who not only minimize the complication by a good transplant, but once the patient have complication, you have the ability and the capacity to manage these complications and hence reducing the mortality. So in summary, I would say that living donor liver transplantation has evolved over time as a definitive therapeutic entity in countries where disease donation does not exist or it's at a very low level of activity. The fundamental knowledge of liver anatomy and physiology and the highest level of technical expertise is required to get good outcome. And in my view, the technical details of living donor liver transplantation are fairly sorted now, but the biliary complications remains the Achilles heel and still some technical sorting out. Thank you very much.
Dr. Faisal Saudar Sahab, you have reignited my interest in surgery with your talk, I must say. So, and I'm sure most of the audience are feeling that way because I could see the chat section buzzing with questions. And I would like to remind them that we are looking at your questions and we will ask and discuss your questions in the upcoming Q&A sessions. So for the final talk for today, we have Dr. Muhammad Saleh from Rawalpindi. He will shed light on what to anticipate in the first year post liver transplant. A few words about Dr. Saleh. He is currently working in the Department of Hepatology and Liver Transplantation, Quaid-e-Azam International Hospital, Islamabad, and he's the Director Hepatology, Consultant Hepatologist and Gastroenterologist over there. He's an ex-assistant professor at the Department of Medicine, Aga Khan University of Pakistan. He's the faculty in the Development Award for Training in Liver Transplantation at University of Pittsburgh Medical Center, USA by the Aga Khan University, Karachi. Dr. Saleh, please take the screen. Thank you very much.
Thank you, Yasser, for a nice introduction. And I'm really honored to be part of this symposium or this conference, sharing my thoughts. My topic is to present on what to anticipate in the first year of the post-liver transplantation, the first year of post-transplant. So it's only anticipation, and my talk will be really easy and simpler. And as you said, that will just prime the audience with the difficulties which we may anticipate in the first year. So we know that the 1 year survival of the liver transplantations is now in the 90s on average for majority of the indication, and the 5 year survival is now somewhere between 70 to 85%, and even the 10 year survival is now about 60%. So liver transplantation has now been accepted as a definitive therapy since the 1980s. What to expect? Sir, hello.
And Dr. Saleh, do you want to share some slides, or you are going along just with the discussion?
I'm sharing. Sorry.
No, we could not see that. That's why I asked.
Sure.
No,
since 1980s, it is now the acceptable definitive therapy for the chronic liver disease and hepatocellular carcinoma and other liver diseases. So when to expect or suspect in the first year, and what to expect or suspect. So if we see that the post-liver transplant follow-up, and we sort of see over the time, so what we'll be expecting in the first 3 months of the liver transplant is basically the most sinister of all of them is the hepatocytic thrombosis, the venous thrombosis, the biliary leaks, of course, the infections which are most common in 90% of the time. We may lose our patients in grafts, specifically bacterial, and so are the viral and fungal. Bleeding at times would be deleterious, and also not to forget about the rejection at the same time. Drug toxicities, nephrotoxicities, and we do see transient hyperglycemia, if not the new onset diabetes, which we do see after post-liver transplant. So transient liver hyperglycemia is there. So we need to, these are the few commoner ones which we see in the first 3 months of the liver transplantation. And in the next 3 to 12 months or up to 1 year, these are basically the biliary strictures, recurrent diseases, nephrotoxicities, new onset diabetes, and CMV. And of course, the rejection, and so is the, if we say TCMR or acute cellular rejection. So these are the fewer, most common anticipated complication in the follow-up in the first 1 year. And these would remain like that in the first 1 year to 5 years, like so. Of course, nephrotoxicity and cardiovascular and dyslipidemia will also chip into it. And later on, then mainly if the graft-related issues are less common, and more will be so as the nephrotoxicity, diabetes, cardiovascular diseases, malignancies, and recurrent disease also. So, and this, when we follow these patients up, the graft-related or the issues and complications are much higher in the first few months and years, and then the once we cross around 3 years or so, immunosuppressant-related issues, rejections, chronic one, malignancies, and cardiovascular complications, and chronic diseases will take over. That brings us to the topic of graft-related issues, and we will focus only on few, not on the on all of them. And The patient usually present with milder symptoms or at times even with main symptoms of jaundice, itching, and ascites, but majority of time they may be only showing a little bit fatigue or failure to thrive after transplantation. However, a majority of these patients are picked up on routine and planned follow-up visits rather than when they present with symptoms. How do we approach these patients when they have abnormal LFTs? And these are, I would say, first you look at the drug toxicity. This is not that uncommon. And if you are sure that there is one, you stop that drug and then will repeat LFTs in a week or 10 days. If there are no drug toxicity suspected, you do an ultrasound. And what we see on ultrasound is that ultrasound with doctor. Are there any hepatic artery flow related or the venous flow related issues, or this ultrasound is plumb normal, or we do see some dilatation on ultrasound which may tell us about the biliary obstruction, or even we may see a steatosis on that. So, and accordingly we move forward. If there is artery or vessel related issues, then you do an angio or MRA or a conventional angiography even. But if the ultrasound is normal, so we look for we proceed to liver biopsy, and then we see that where there is a recurrent disease or where is rejection, or and then out there is drug toxicity, and you will treat accordingly. For biliary obstruction, of course, so we need an MRCP, and then accordingly we progress to an ERCP, and if you fail, to go for the percutaneous approach. Of course, one should also keep this patient on antibiotic at the same time. And steatosis we deal, because this is also an important issue, and we should treat them accordingly. So the graft-related issue for rejection is basically T-cell mediated rejection, which may be an acute or late, and even maybe chronic one. Of course, the antibody-mediated rejection is also there, and one should look for it at times. The vascular complications, and then the biliary complications, and of course, do not forget the recurrent disease. So these are mainly the graft-related issues, and we will take them one by one briefly. For the management of acute rejection, which we call the T-cell mediated rejection now, it depends on the severity of that, and of course, a biopsy is mandated for that. And if it is a mild one, there is no need of steroid boluses. One would just optimize the calcineurin inhibitors, and one may add mycophenolic acids, or even you may add an everolimus. It depends on the kidney functions and your choices, or the availability. Of course, the moderate to severe would require IV pulse therapy for somewhere between 3 to 5 days, and then followed by tapering steroid doses. One would, of course, optimize the CNI, and even may add the mycophenolic acid or everolimus at the same time. If the acute cell rejection is with severe cholestasis, which may progress to ductopenic rejection, then of course this is the sinister of all, and one should manage these with steroid pulse therapy, optimize immunosuppressions, and even one may give them immunoglobulins or lymphocyte depleting agents, and may consider monoclonal antibodies as well, as these are the most difficult patients to rescue if they are having severe cholestasis with rejection. The biliary complications are of two types mainly. There's the leaks and strictures. Of course, the leaks are the early one, and the stricture would follow. The incidence is somewhere between 6 to 27%, and the type of biliary leaks would be anastomotic or non-anastomotic, and usually cut surface small leaks are there, and most likely secondary to the caudate duct leak. Presentation is usually in the first 2 months. However, the first 2 weeks are important, and majority of them will present in the first 2 weeks. The management of small leaks are conservative. However, proper biliary leak would require endoscopic therapy, and if that fails, one may take the help of an IR, interventional radiologist, and rarely surgery. For biliary strictures, the chances are somewhere between 20 to 32% or 20 to 30%, and most common surgical complications of the living donor liver transplantations is the biliary strictures. The presentation they were presented any time. Recently, I had a patient who was transplanted in 2013, and now in 2020 he presented with a stricture. However, the median presentation time is 6 months, and up to 90% of them would present in the first year of life. The type of stricture would be an anastomotic and non-anastomotic. An anastomotic is single, and they are at anastomotic sites. The localized fibrosis due to operative techniques, biliary ischemia are the main factors behind these strictures, relatively more common in 2-in-1 ductoplasty, and more so if you have got more than 2 ducts, 2 anastomotes. The non-anastomotic strictures are usually multiple due to diffuse process and mainly due to ischemia or immunological injury or bile salt, biliary salt related cytotoxicity. Less common in LDLT due to shorter cold ischemia time. However, we do see them at times, specifically if you've got hepatic artery related issues in the immediate post-operative periods. Once you have these strictures, what you do is you go for an ERCP. You are allowed to have 2 attempts at the endoscopic through endoscopy. If that fails, then you ask your radiology colleagues, and even a rendezvous technique may be needed. However, if that has failed, then of course surgery is the last option for that. If you have got a successful cannulation either by ERCP or with the help of a radiologist, then you will have either it is a stricture or leak or a stone. Of course, for stones, it's simple. You do a sphincterotomy and clear the ducts. For biliary leak, again, the stenting, the biliary sphincterotomy and plastic stenting is required. For biliary stricture, it would depend whether you have traversed that or not, and you have traversed all of the strictures. At times, there are more than 2 ducts or more than 2 sectors, so you need to have a selective sectoral cannulation as well. And you should have your biliary anatomy and MRCP at hand to know are you draining the whole liver or not. So if you have successfully traversed the stricture, of course, you need a sphincterotomy, dilatation, and followed by stenting. They would require on average 3 to 4 sessions, if not more, along with dilatation and putting up multiple stents. But if you have not traversed that, then the percutaneous route is needed, or even at times cholangioscopy may help you. Of course, if everything else fails, we ask for surgical colleagues to intervene. The vascular complications, the hepatic artery thrombosis, usually in the first 2 weeks, I would say the first 2 to 3 days are more important, but late head would occur, though it's less devastating. Hepatic artery stenosis would take a few weeks to several months. The portal vein thrombosis, usually within the first month, and the portal vein stenosis and hepatic vein stenosis usually would take a few months to clear. How do we diagnose these vascular complications? Is usually by doctor and MRA or CT angiography, and at times conventional angiography is needed as a diagnostic and therapeutic modality. So ischemic complications is the hepatic artery stenosis or delayed head, usually present with non-anastomotic stricture or sterile or infected fluids in the liver, at times referred to as biomas, and ischemic cholangiopathy and biliary cause syndromes. If we do get the hepatic artery stenosis, of course, it would require diagnosis, and then intervention radiologist would intervene, and dilatation and stenting is required. For portal vein stenosis, intervention radiologists would help us by dilatation and time stenting. Venous outflow issues, they're usually present with deranged FTs, but most of the time is ascites or pleural effusions, which one should suspect, and Faisal referred to these, that how do we take care of the outflows. We do diagnose them on hepatic, on doctors, and at times on even can have from the CTA or the MRA. Hepatic venous stenosis, of course, we ask our radiology colleagues to intervene, and they are being dilated and even at times stented, and the issue can be solved that way. Infections, of course, viral, bacterial, and fungal, all these infections can occur, and one should never forget the opportunistic one. And that they would like in the early periods is basically pneumonia, surgical site infections, collections, secondarily getting infecting, and urinary tract infections. And one should never forget, even in our countries, like Clostridium difficiles related infections. And so is, and there are a few factors for that. If your patient has an ICU stay or required prolonged mechanical ventilations or surgical techniques or wound infection, or whether the patient had hepatic artery thrombosis or not, or had some biliary complications. So they would all predispose these patients to the infections in the first place. And one would have at times very nasty bugs growing up, and more so if you have got biliary complications. Later in the first month or so, if you have not prophylaxed them universally, CMV is the most common one. Of course, we do prophylax them for the pneumocystis pneumonia as well. And in our country, one should be also, always careful about the tuberculosis. Later on, if you have prophylaxed them, the late onset CMV will be there, and then the community-acquired infections, one should be very careful. Please do remember vaccination, the mandatory vaccination pre-transplantation on the waiting list, as well as all your cirrhotics should get vaccinated. And please, may I take this opportunity to remind all our colleagues that the October, November is, or the fall is these are the months to have your patient vaccinated against preventable diseases like pneumonia and flu and all the meningococcal, etc. So do remember to vaccinate your patients in October, November before they get these. Recurrent disease, do not forget the primary disease recurrence, and also the other one is de novo autoimmune hepatitis. So one should be looking for these because patient would present to you with the deranged LFTs, and of course one should follow the algorithm and through liver biopsy or through serology and viral testing, one can diagnose them with the primary recurrent disease as well. So the main thing is that the first tune is in the follow. So you need to follow these patients up. You need to remember, and you need to act accordingly. And that's what you are going to anticipate in the first year of life post-liver transplant in a simple way. With that, I will thank you all for your kind listening. I'll be happy to take questions. Thank you.
Amazing talk, Dr. Saleh, and very precisely phrased and summarized. I'd absolutely love to see you on screen whenever you are talking, and the content was absolutely bang on target. So we are well in time, and the best part of the session is just about to begin. It's going to be an interactive discussion between the panelists, our facilitator, and anyone who wants to join the conversation directly. We would encourage to raise their hands and put up their question. If they want to ask this question specifically to someone from the panel, we would highly appreciate and encourage that. So first of all, I would like Dr. Shehzad Riaz, our facilitator for the session, to please come on screen. Dr. Shehzad Riaz, can you join us? Please.
Yes.
Welcome, Dr. Shehzad. So I've been seeing that you were answering the questions at such a high speed that probably all the questions have been answered already. And but we have still 20 minutes in the session, but you have to do something about it.
Yes. Well, I just wanted to first thank all the speakers and the panelists for coming and giving such a wonderful session. It was very informative. We had a very good blend of East and West. I think the key thing with transplantation is that although there are a lot of similarities between the West and in Pakistan, but there are certainly some differences as well. With the living donor transplantation, the timing of the transplantation, the patient's needs, their socioeconomic status, etc., is quite different from what we experience in the West. So I think I would just kick off the questions I was just noting down. Was with obviously Dr. Faisal has got loads of experience, and Saleh as well, and Haseeb. what is your experience with regards to the poor nutritional status of our patients that present with transplantation? So on one hand, we would ideally like to optimize their nutritional status before offering them a transplant to improve their outcomes. But on the other hand, the socioeconomic status, the situation of their finances, the overall effect is such that we tend to want to transplant them sooner as well. So do you guys would like to comment on this, and do you guys have a cutoff before which you do not offer these nutritionally depleted patients any transplantation? Dr. Faisal, if you want to start off.
Unmute yourself.
Yeah. I mean, poor nutritional status is actually a bad thing to start. And whenever we have tried to compromise on the nutritional status, we ended up in a bad outcome. It is always a challenge to improve the nutrition of these patients.
Dr. Faisal, we cannot hear you properly. If you can speak a bit louder.
I mean, it is always a challenge to build up the nutritional status of these patients. It is tough because most of these patients are nauseous because of the portal hypertension. And the other part is most of our patients actually come to us quite late in their liver disease stage. So on one hand, you want to build them nutritionally, which is going to take a bit of a time. And on the other hand, you are fighting on time because they are so sick that you have to transplant them. That remains a very difficult area. And to be very fair, I don't have an answer or a therapy to build them in a very fast track session. And I would like to hear from others if they can.
May I say something? And I don't know how to translate it, but you cannot sort of make your horse train or make it fatten during the wartime. So when the patients are referred to us, that was basically what I translated from the Pashto. So you cannot make them like that, because patients are referred to us with a MELD sodium of around 30 or so, or 27. And then you have a little time to deal with them, and God forbid, you may lose them at times. So probably we need to work with the child A and child B patients more, and taking this opportunity and reminding all of us that we should be encouraging the diet. Even I can see Professor Altaf Alam and Jayed Farooq in the panel as well, but even they are writing on their prescription, take normal diet. But the taboos and all those myths and beliefs are there that nobody would take a normal diet and they would just go pure vegetarian and all that stuff. So we need to make them walk. We need to make them take normal diet. So we need to remind ourselves and our colleagues all the time. And I must admit that this is a neglected part. And even recently on the last Monday, we had a discussion in our listing meeting. Faisal would remember that. That is a neglected part, unfortunately.
Excellent. Any other of the panelists would like to comment, please?
Dr. Haseeb wants to say something, I believe. Can we unmute? Oh, he's unmuted.
Can you hear me, all of you?
Yes, we can.
Okay, so I'm just going to add on what Dr. Faisal and Dr. Saleh said. But if you ask the surgeons the wrong question, because the patients reach our offices and our clinics at the time when they are ready to get the transplant, and most of the times we just have a couple of weeks, maybe 2 to 3 weeks before we actually offer them the date and give them the date for surgery. So I would stress if the primary physicians and the gastroenterologists who have had these patients for a number of months and years, if they were to really push this side of the management, and because you cannot correct nutrition within days. It has to be a continuous process, and it usually should take a couple of months before they are in a good nutritional state. All I can say is whenever we transplant patients who are nutritionally depleted, as Faisal said, the standard line is from surgical perspective, the patient looks too weak, but yeah, if she needs a transplant or he needs a transplant, and then we transplant them, and everything has gone well, but still the patient's outcome was not that good. So it just sort of, because these patients will just sort of fade away after the transplant. And that's what we see every couple of months. One of such like patients, they will just not have the desired outcome. So yes, nutrition is very important. People have a lot of disbeliefs about what to eat, what not to eat. We have nutritionists on board, but they're not really coming up. So exactly the point of Dr. Saleh, we need to really push this aspect of the management. And I think it has to be more physician centric. That's what I will be saying.
That's very well said. And I think the key thing that you guys all have emphasized on is that it is very, very important. However, at a national level as well, especially in the gastroenterology community, the awareness of this needs to be increased. And ideally at the PSH level or other organizational levels, guidelines should be made. And all the hepatology and gastroenterology colleagues should contribute towards it, to building up these patients so that they can have a good outcome. That's fine. Thank you very much for that answer. Any other questions that anybody or any other points that anybody would like to add before we go to the next question?
Dr. Shahzad, there was a very good question about routine practices. Somebody asked in the question section that how frequently are patients reevaluated in the clinic after listing in the UK? What are the indications of delisting in non-HCC patients? This question was directed towards Dr. Tehami, and he has already answered it. But how about we compare it with our practices in Pakistan? I believe Dr. Faisal, Dr. Hasib, Dr. Saleh can give us a comparison with the practices in UK versus Pakistan.
So should we start with Dr. Tehami to mention it?
Yes, Dr. Tehami, are you there? I believe he's not there. Yes, he's there. Oh, sorry.
Sorry, what exactly was the question?
Dr. Tehami, if you are there, can you
want
me to repeat the
no,
question?
thank you very much. Thanks for unmuting me. So the answer I obviously gave on the chat was that in before COVID era, we used to sort of see them once a month. And that would include obviously an assessment in a multidisciplinary clinic where we have nutritionist, surgeon, physician available. And this is the time when you obviously just go through all their blood tests just to ensure that their MELD or UCAL, whatever the start-off point was the same. We'd still take into account this Child-Pugh scoring just to make sure the patient is stable and remains stable. Now, as it's different, obviously, from our perspective, because our patients have to wait for months before they come to that stage where they get transplanted. So this gives us the ample time to work on their nutrition as well. Now, I guess this is clearly different from when you're looking at from Pakistani angle, because things are really different and different. I think they're two completely different worlds, the living donor and deceased donor. So the pre-COVID area used to be face-to-face appointments. These days it's mostly virtual or telephone clinic appointments. And given that we have time in our hands, or you can take it the other way, that obviously there's a delay. So our focus is in those clinics, make sure that we continue to focus on their nutrition. And if they've got an underlying etiology, we just focus on working on that as well.
Excellent. Anyone out of the other panelists would like to comment on it?
We were talking about...
Sorry, there's one more thing. Sorry, the part of the question was also about delisting. So I think if you just take the HCC out of it, so it's there's a different part of it. So there are one group of patients who are deemed too sick to have a transplant as the time progresses because they've been waiting too long. There's one group of patients who may develop an added infection, or they become unwell, or they develop a acute kidney injury or hepatorenal hepatorenal syndrome. In those cases, those patients are suspended from the list, but they're not delisted. So there's a difference between a patient who's completely taken off the list. Either they become too unwell, or they have recompensated following treatment of their initial condition, or then the patient is suspended because they've got an additional problem while they're waiting for it. So that also needs to be taken into account. But that's again the role of transplant coordinator comes into play, because once the patient improves, then we really need to communicate to the transplant unit again via coordinator and try to relist those patients.
Dr. Tehami, what have been the results of all this intervention? Have you been able to successfully build up the nutrition of these patients?
So, I mean, the thing is, again, given the work that UCS guys have done on this frailty index, and I think that's quite monitored. So if it is more than 4.5, you know this patient is not going to do well. And I think that's how they have coordinated in one of their recent studies. Yes, I think, it is, if I don't have a data to quote, but there were patients, especially those who were listed for alcohol-related liver disease. Once they've given up, and I think this is similar to what Shahzad Riaz answered to one of the questions, that patient, when they presented, they were too sick and they were listed for the transplant. They had to wait for a certain period of time. In this time, we worked on their nutrition. And there is a group of patients who were then sort of taken off the list, not because they became too unwell, because they recompensated and they didn't need the transplant in the first place. So that's all I can sort of say from a non-transplant unit's perspective.
The key thing that you have mentioned, Nadeem, which is very important, is that on one hand, the waiting lists in the West are quite long. So they could be on average up to a year waiting for a transplant. I mean, and from the day they develop ascites, the median survival is 2 years anyway. So that's why once they are on the list, they ideally are kept on the list. They are sort of made deactivated, but not taken off the list. But on the other hand, quite a few of the pathologies in the West are reversible, such as an alcoholic hepatitis. The liver has the opportunity of recovering. So those particular patients in which the UCALD goes below 49, they are recompensating, their Child-Pugh score are improving. Those particular patients are taken off the list. In Pakistan, the situation is slightly different because most of the cirrhosis patients that have end-stage liver disease do not have a reversible element to their disease. So there's not much autoimmune hepatitis, for example, or alcoholic hepatitis. So once they are on the list, they usually require a transplant. And also because of the shorter waiting times, they are usually transplanted fairly rapidly.
That's correct. So basically, it's the point here is attention to detail. So if somebody walks into the clinic with decompensation of their liver disease, so what should go through a physician or a surgeon's mind is that from one end, and is this patient transplantable? Does he fulfill the criteria? And on the other hand, is this person going to need a palliative care? So it's just complete you have to look at the whole spectrum from all possibilities of somebody just ending up requiring palliative care to somebody who's then ended up successfully transplanted. Nutrition obviously is the key. We have talked more, we can go on and on talking about it. There's two further elements to it. Obviously one, as people have said, it takes a long time for them to build up a muscle mass. And therefore obviously you need to sort of get them to increase the nutritional intake. But also part of this is also their electrolyte disturbances. So their sort of small minerals, micronutrients that you have to talk about. Those are the things that can be corrected easily, because as obviously I mentioned in one of my slides, if you look at obviously your HRS, although we don't talk about type 1 and type 2 these days, but those people who end up developing any of those complications, their survival isn't great. So on one hand, building up their muscle mass, working on it. And again, if you've got a limited time left, then correcting all those minerals, micronutrients, ensuring their sort of renal function are stable. I think that's all you can give as a general advice. But it's important because it's a very complex area. So therefore, you need expertise of the people who know what they're talking about. So especially when it comes down to nutrition and dietitian, there are people who have special interest in it. And I think therefore, those are the people who should also be taken on board.
Dr. Shahzad, I believe we are underutilizing the presence of Dr. Nora here.
Yeah, sure.
We would like to take her comments. And one question is also directly directed to her. An audience has asked that any thoughts on your local experience for acceptance among organ donor groups for hot OLT in alcoholic hepatitis? This has been an obstacle according to our attendee. So Dr. Nora, can you please take up the question?
Thanks for the question. And I'm enjoying the discussion about nutrition. It's sort of a big issue for us as well, and frailty. So it's very global, this concern about the status of the waitlist patients in terms of nutrition. But in terms of alcohol, this is, clearly I see the comments in the chat, and I think this is still reflecting the fact that this is a controversial area, and a lot of programs have not adopted the offering of early transplantation for patients with severe alcohol-associated hepatitis. I'm going to emphasize severe, right? So I agree with you that some patients with alcohol-associated liver disease who present with decompensation have the opportunity to improve and actually not require transplant. but we're choosing patients with a very high mortality, as reflected by the studies which show that the 2-year survival in those not offered transplant is only about 20 to 30%. So, I think that there is some need to rethink, offering it in a very selective fashion. But to come back to the question of whether that might influence donation, because that is one of the perceptions, is that if you start offering liver transplantation to patients who are drinking up until the time of their transplant, that this is going to lead to decline in donation. And the best data we have, at least in the United States, is they did sort of crowdsourcing where they surveyed individuals who stated that they were going to be donors. And it showed in that very large survey that 75% of individuals said it wouldn't influence their decision to donate. And that up to 85% were at least neutral. So yes, there's a small proportion of donors who would say that they may be influenced in a negative way not to donate, but in the vast majority of individuals are at least neutral or are okay with the idea. And I think we need to change sort of public opinion about alcohol use, that this is a chronic disease. And I always like to make the comparison to NAFLD. So we have many people who are overweight, who have an eating disorder, basically, and have led to obesity and fatty liver disease. And we don't question their suitability for transplantation, although some of us have BMI cutoffs. But somebody with alcohol use disorder, which is also a chronic condition, an addiction that needs to be managed, we stigmatize that in a way that we exclude them from consideration of transplant if they've recently used. So I'm not saying that we should open up the gates to individuals with alcohol use disorder. I think we have to be highly, highly selective. But I am an advocate for us changing our thinking and acknowledging that if we change the way that we characterize alcohol use and alcohol use disorder, that will also influence public opinion and the willingness to donate.
Dr. Nora, can I just chip in and ask you
Sure.
an ethical question here? That in societies such as the UK, where acute alcoholic hepatitis patients are not routinely offered transplantation because of their alcohol use, should those patients be offered live donor transplantation, or should that not also be on the cards?
My opinion about living donors in general is that if you wouldn't offer a deceased donor to that patient, you shouldn't offer a living donor. So I think the criteria should be the same. I know that it's about we don't have enough donors, but it really is about selecting the right patient to have the best outcome. I think if you just took every patient who happens to have a living donor, then we're going to end up having patients not do as well post-transplant. We are being selective. The psychosocial profile is relevant and important. I think if you have a selection process that allows you to take such individuals that you think are going to be at relatively low risk for sustained and heavy alcohol use after transplant, then I would be fine offering them a living donor as easily as I do a deceased donor. But I wouldn't differentiate. Do you see what I'm saying?
I completely.
Go ahead, please.
No. So I completely agree. So as I said, when they come across the first question, obviously we do ask them, does this patient really need a transplant? And then the second question is obviously, is this patient going to survive the transplant? And then the third question is obviously, am I going to be doing a justice if I transplant this patient? Now, given obviously when we've got a limited donors here, then it becomes really challenging. But as you've said already, I think I completely agree with that, and Shahzad mentioned that as well, that we obviously we should hate. We shouldn't hate the patient. Yes, the disease is something that, yes, we don't like it, but we shouldn't sort of stigmatize those patients. It just brings me an example of a 70-year-old lady recently we saw who were excluded from her church group because she was tested positive for hepatitis C. So stigmatizing is obviously sort of does completely the opposite thing that we want to achieve.
Would the surgeons, Dr. Haseeb or Dr. Faisal, like to comment on offering live donor transplantation to acute alcoholic hepatitis patients in view that it is not a limited resource back home because the patient brings their own donor?
I would just like to take you back into the early 2000s and maybe late 90s, when hepatitis C was a problem. And that was the predominant indication for transplantation in the United States and in Europe as well. And there was no ethical discussions about transplanting and then retransplanting and then retransplanting and then retransplanting for hepatitis C. I personally have been a part of a transplant on a young man who was transplanted 5th time for hepatitis C. So there was no ethical dilemmas at the time because that was not that man's fault that he got hepatitis C. So I think we need to be a little gentle with alcoholics as well. They are not normal. At least if somebody is young, I think they should be given at least one chance with the transplantation. If you have a facility of deceased donation, obviously that is a priority. But if they come up with a living donor, in my view, they should be given a chance. It's very hard. If somebody is in 32, comes with a liver failure from alcohol, how you can just say that we cannot transplant you? I find it very difficult in young people. So I personally would give a chance.
Excellent. Anyone else would like to comment? Dr. Altaf, would you like to comment on it?
No, I was just wondering, we have Rustam Khan here. Would you like to comment on sarcopenia and malnutrition, and what do you propose we do it in our setup to get them better before transplant?
Thank you, Dr. Altaf. This is a very practical question, and usually our patients are sarcopenic and have frailty, and it is very challenging to get them to the optimal level, but we should have some compromise level before subjecting the patient for liver transplantation.
I would also like to ask Dr. Rustam maybe, or the other physicians here in the panel. Nadeem Tehami's presentation had a small portion saying exercise. So I would like to actually complicate this matter further. The general understanding is that a cirrhotic patient who can barely do a 6 minutes walk test, it is a common question which I am asked in the clinic and about the exercise. So I really don't have the answer. The standard answer from my side is as much as you can. And then I have seen patients. I actually saw one patient who would, he was a climber, and he used to go to the hills and the mountains. And whenever he would go on a small expedition, he would become encephalopathic, he would become, he would raise his bilirubin and come back. And then, you know, that was the cycle he was undergoing for the last couple of years. So I have an understanding that exercise puts a sort of a burden, and that the tendency for the liver to decompensate increases. So where is the cutoff, and what is the cutoff? So it's a sort of a question for the physicians.
And before Dr. Tehami answers, I just want to add a little flavor by taking it on the lighter side. I mean, Nadeem said that replacing the micronutrients will help. Yes, I totally scientifically agree that these patients do have zinc, selenium, and all these deficiencies. But if somebody cannot walk for 6 minutes and is absolutely skin and bones, I think just pushing micronutrients is not going to help. He needs solid proteins.
Absolutely.
I would take this an opportunity, because these patients comes to us when they really need a transplant. They have been with the gastroenterologist for years for hepatitis C and all those things. And they have all been completely denied of proteins. I don't know where it comes from, and absolutely malnourished, and it continues even today. So I think this is an opportunity for all our well-known gastroenterologists and hepatologists to please pass on to your message to your colleagues that you are making these patients even more vulnerable to become sarcopenic, and by the time they come transplant, we don't have much time, and just replacing micronutrients is not going to bloat them up and fit for transplant.
No, I completely agree. I'm sorry this wasn't the way I want to portray it. What I was trying to allude to, that obviously on one hand, you really want to work on their muscle build-up. And on the other hand, if you don't have a time, and as Dr. Asib has said earlier, you've got about 2 weeks time to list these patients. And in this time, obviously, you do not have enough time to build that muscle mass. So what can you focus on? So the things, as I said, if you can focus on their hydration and electrolytes, is at least will prevent them from developing sort of acute kidney injury or hepatorenal syndrome. So this is what I was referring to. And you've also, I think, answered in your own comment that things like, so if you've got, say, for example, you've got evidence of using maybe zinc sulfate for treating patients for in hepatic encephalopathy, which again is directly correlate with the patient's outcome. So I think that's where you have to look at from. Now, I mean, exercise, you're very right in saying that there is very little data out there in patients who are waiting for the liver transplant. But what these programs do, I think what they do is they improve the patient's functional capacity, and it improves their sort of adaptive and coping mechanism. Because what you're not doing, we're not just only building their muscle strength, we're also sort of giving them an exercise to improve this, so their improving their cardiovascular stability as well. And I guess when these patients go through for the initial assessment, and again, for the CPAC scan, most of the time people are turned down for any operation, let alone a transplant operation, on their ability of not sort of having reaching enough aerobic or anaerobic threshold. So I think what exercise does, it helps in several ways. I wish I had a data to support it, but that's how I would answer it.
May I say something?
Yes, Dr. Saleh, please.
So on a lighter note, once I was presenting on hepatic encephalopathy, and this protein issue would always come up, and somebody asked me, and I responded, and I repeat here, that in my 200 years of experience, clinical experience of practicing in Pakistan, I have seen only 2 patients going into hepatic encephalopathy due to proteins. And somebody questioned that I think at that time, 37 years old or so. And he said, 200 years of experience. I said, yes, 37 years of Professor Jaffrey, around 30 years of Professor Saeed Hamid, and 30 years of Dr. Zagham, and all those, because I listened to them. And there's only 2 persons who have so far communicated to me that one of their patients went into hepatic encephalopathy due to proteins. So one is that. So our patients rarely would go to, there are few who would take a full, I would say, a goat or something and one dish, and they may go into hepatic encephalopathy. The majority of them will not. The other thing is that, well, you may not make exercise or make them or ask them to climb hills, but at least make them walk. Make them walk at least. And I would say so that the hand grip exercises and even stretching a little bit of exercises, they will keep them in shape. It's not only the muscle mass, it's sort of the whole body well-being, which will keep them. And we also know that the post-operative morbidity, mortality is related to even just making them, while they are on the waiting for transplantation, even simpler exercises like the incentive spirometry will help. So all these bits and pieces would make a little bit differences, including, of course, diet, and please encourage proteins.
I think
thank you very much.
So that's very well said. I think the key message that we have all emphasized on is the importance of nutrition. The problem is that the dynamics are such that by the time the patient comes to the transplant unit, because they have collected their funds, they have arranged the donor, there are other dynamics as well, that even in patients who don't imminently need a transplant, they end up getting transplanted because of various socio-economic and factors. They will run out of money, for example, for a transplant if they are not transplanted within time. So I think, but the key message to the gastroenterology community, to the physician community, to the non-transplant community, is to ensure that that nutrition is part. It's as equal as putting them on a PPI or a beta blocker or on the medication, to ensure that their nutritional status is assessed and they are provided with adequate nutrition. Okay, so
Dr. Shahzad, as much as we all are enjoying this conversation, and I want it to go on for like 2 or 3 more hours, but we have a very restless bunch on the other end of the table who want to throw us out. So
can we just take one
running
last
out of
opinion
time, actually.
I'm really sorry to interrupt. Can we just take one last opinion from Brigadier Amjad Salamat? I think it is a very, very important point to make. Please.
Yeah, just thanks so much for letting me. I'll be quick.
I think just this whole discussion emphasizes one point very strongly, and that is there's not enough specifics, or somebody needs to generate data, what works and what doesn't work, what strategies are there to be. So till we have that generation of that data and what works and what not, I think it's going to be an opinion. And I think that is one of the reasons that many people do not actually emphasize that they don't know what to do with these patients. And that's true for a lot of gastroenterologists, because some people ask, okay, we went to the other doctor, he said this, you're doing this, you're saying this, so that's why. So I think we need to emphasize to the research community that they need to generate a robust data so that we know specifics, what to do and what works and what doesn't work.
Well said.
With these golden words from Brigadier Amjad, I would humbly request our panel to allow me to end this session. I would extend my deepest gratitude to Professor Sher Rahman, Brigadier Amjad Salamat, Dr. Rustam Khan, Dr. Haseeb Haider Zia, and above all, our facilitator for the session, Dr. Shahzad Riaz. He has been a wonderful facilitator and kept us going on and on. So thank you very much, everybody. The upcoming session is the next plenary session, and it's about HCV elimination from Pakistan. Dr. Asad Chaudhary, who's doing a wonderful job in this field, will be the moderator for the next session, and hope to see you in the next session, everyone. Thank you very much. Thank you to everyone who has been with us. Goodbye. Allah Hafiz.
Thank you very much. Thank you.
Thank you. Thank you, Dr. Yasir. Thank you, Dr. Hami.
Thank you, sir. Allah Hafiz.
Thank you, Dr. Khalid.